Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you to today's webinar entitled New York State Council of Health System Pharmacists Pharmacoequity Miniseries, Part 1. This is supported by an educational grant provided to the REF by J&J Innovative Medicine, and it is a part of a larger effort to launch a grant around a research grant around the impact of pharmacists on health outcomes in patients that have health disparities. As part of this, we are thrilled to have Dr. Gina Prescott, Dr. Sarah Amering, Dr. Jennifer Travato, Dr. Hanlon Lee, and Dr. Amber Bradley, all as our guests who will present this evening. Dr. Gina Prescott is a clinical professor and director of global and community outreach at the University at Buffalo School of Pharmacy and Pharmaceutical Sciences. She has an ambulatory care clinical practice at Jericho Road, a migrant, immigrant, and refugee clinic in Buffalo. She is responsible for teaching curricular content on social and structural determinants of health. Her research is focused on non-communicable diseases and health equity. Welcome to Going the Distance, Improving Access to Medications for Patients with Safety Net is the title of Dr. Sarah Amering and Dr. Jennifer Travato's presentation. Dr. Amering is a clinical pharmacy specialist in primary care at the University of Rochester Medical Center. She practices comprehensive medication management in a collaborative team-based environment. Dr. Travato is a medication management pharmacist within the University of Rochester Medical Center, specifically coordinating care for patients at Manhattan Square Family Medicine. Dr. Travato has worked in this role for the past 1.5 years and was the initial pilot for an embedded outpatient pharmacist within the clinic setting. Dr. Lee, the ambulatory care lead clinical pharmacy manager at New York Presbyterian Hospital, oversees a team of clinical pharmacists, pharmacy interns, and technicians. Her expertise lies in primary care and chronic kidney diseases, where she leverages collaborative drug therapy management agreements to enhance patient outcomes. Her performance history encompasses implementing cross-functional organizational initiatives to expand the ambulatory care pharmacy programs and drive operations improvement, utilizing technology and digital visualizations. And our final speaker today is Dr. Amber Bradley. She is an ambulatory care clinical pharmacy manager at New York Presbyterian Hospital, practicing in an internal medicine and infection diseases clinic. Amber has played a crucial role during the development and implementation of postpartum hypertension clinic. So please join me in welcoming all of our speakers. Before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat function to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option. And the CE code for this program will be provided at the end of the program. So without further ado, our first speaker is Dr. Gina Prescott.
Good evening, everyone. I will be talking today about integrating clinical pharmacy services at a federally qualified health clinic serving refugee, immigrant, and low-income patients in Buffalo. As discussed previously, I am a clinical professor at the University of Buffalo, and my clinical practice site is at Jericho Road Community Health Center, which I will discuss later in the presentation. The objectives of my part of the talk today are to identify social and structural determinants of health that impact immigrant, migrant, and low-income patients in an ambulatory care clinic, to describe the focus of the clinical pharmacy services in addressing health equity and chronic disease management, and to illustrate how to integrate learners in achieving service goals. I have no financial interest to disclose, but I would like everyone to know that part of this presentation was completed as a descriptive research project and presented at the American Association of Colleges of Pharmacy annual meeting this past July. Most of you are probably all familiar with Healthy People 2030. I just wanted to review the overall concept of this because it's the main model that we use for learners at our clinic. However, this particular model and how it's outlined is really structured around social determinants of health, as opposed to the broader view of structural causes. Although they're integrated, they're not well highlighted, and the current model as it's laid out here, where it defines the 5 main regions of social determinants of health, including economic stability, education, community and social context, healthcare system, and neighborhood and built environment. So there's these 5 main regions. However, there's also this aspect of food insecurity, which I think is an extremely important social determinant of health that pharmacists can be very impactful for, especially when you're discussing medication treatments and disease management for chronic diseases. Essentially, food insecurity can fit almost anywhere in any of the 5 different models, depending on whether it's a cost issue, so it fits in economic stability, neighborhood and built environment, because there isn't access, there's not a grocery store, or in our particular aspect, some of it is social and community, because it's derived from cultural difference or what the community does that impacts food choices. So sometimes we separate that out when we're discussing our SDOH models within our clinical practice site. The other part that I like to stress as well are the structural determinants of health. And a lot of times what we do is we utilize this overall table to discuss what are those structural determinants. Sometimes when you're looking at a lot of information on the social determinants, the structures get lost a little bit if they're not clearly defined, or it's difficult to determine how you can address them. And as you can see in this chart, a lot of them are accounted for through a local community environment, and most of these structural issues cannot be achieved through either just a singular clinic, a singular pharmacist. And so what you will see throughout my presentation is how our clinic has been addressing this, not necessarily from the pharmacist perspective, but to give you an overall broader view, how like potentially a system can work to improve these structural determinants of health. Next, I'm going to discuss on my next slide how New York State's social determinants of health is laid out a little bit different, and it's a little bit more cleaner than the Healthy People 2030. So for right now, I would ask for the participants to take a quick poll on how these 2 different models might differ. Okay, so looking at the poll, there seems to be quite a range of a different split. The largest category that is listed is language access at 44%, food insecurity, excuse me, at 26%, and then workforce development follows behind at 21%. I think these are all important because, like I previously discussed, food kind of gets moved all over the place. And I think because of the unique environment that New York sits in, and particularly in my setting, that language access is the one that you see a difference in. Okay, so this is the New York State domains that are out there. And what I did, particularly in my region, and I would encourage all of you to look at your region to see if there's anything available. But my clinic's in Erie County within the state of New York. And so Erie County actually has its own health equity report that it started releasing. I think last year was the first one. The ones that you see in the black and white are additions to the Erie County one beyond what the state recognizes. And as you'll see in the top right portion of this particular slide, they do separate out language access. For myself and my clinic, this is very important. I think it's important across the board as the U.S. Becomes more diverse. I'm sure there's a large group from New York City on as well, and they have a lot of different languages as well. But even within our school system, in the Buffalo public school system, we, I think per capita, have the largest number of languages, either within the state or very close to that. And so there is a lot of different language issues that do occur within our county of Erie, so that is why I believe that is also addressed separately. The other couple that I like to highlight here, because especially in our clinic or as pharmacists, myself, and I will explain how our clinic is laid out, but I'm not the only pharmacist there. I have a co-colleague who works very closely with me. And we do a lot of digital literacy, particularly with diabetes management and access to care in those particular areas. And so I like to use the Erie County model because that is one in which I can address this particular aspect very clearly, and I can also teach learners about this as well. We use this format that's here because, again, it's a lot cleaner. There's a lot more content within the Department of Health and the Erie County social determinants of health domains that are listed here. And it allows you to really think about what are the different roles that pharmacists can play in all of these areas. I'm not saying that that's necessarily what we should do or what you can do based on your practice site, but these will help to expand that beyond just overall economics or overall neighborhood and built environment, to give you an example. And so again, we typically will broaden this New York State Department of Health domains and use the Erie County one. The other ones on the right, the isolation, integration, trauma, and stress, are also important because we have quite a few patients too with like PTSD and things like that, especially upon resettlement, and offer a lot of different services at our clinic that help to deal with that as well. So there have been small numbers of studies, and I know there's going to be some great presentations today that talk about the pharmacist's role. However, when you really look at the literature that's out there in pharmacists and social determinants of health, the actual numbers of studies, and I'm going to emphasize this, that focus on achieving health equity or integrating social and behavioral concepts into studies up front, are actually quite small. I think everyone knows, and there's a lot of colleagues of mine that work in this area at UB with me. Chris Daly and Dave Jacobs have led a lot of work with C-SPAN and community pharmacy access, addressing social determinants of health through screening. And so there's been some good literature that they've been able to put out with some outcomes. And there has been some more recent hospital transitions of care ones that really look at that particular issue, from studying it from start to finish and then having those outcomes. Overall, there has been ongoing, and I want to acknowledge this, and I believe some of this is going to be discussed today. There have been areas in pharmacy that have been looking at MTM programs, payer programs that have been looking at claims data and doing things through the payers as well. Those have become more popular over the last few years, particularly as the call for this has increased. But most of the literature that I've seen that I'm looking for that is specifically addressing SDOHs and structural determinants of health have been more of a generalizability of call to pharmacists as what they should do or how we can do that, or what our roles should be. And so I just want to bring that up because I think that's a void that we need to address, and that we need to think about is how we can start publishing those things that we're doing already, and looking at it from that health equity angle. So what are some of these more generalizable studies looking at? And so this is one of the overall examples that we sort of thought about when we were developing our service at the clinic. Again, our service, and I'll cover this in a few minutes, wasn't necessarily directed at social and structural determinants of health, but naturally through the clientele that we service, it's difficult to address patient care without addressing those, and we know that up front at our clinic. But these are some areas that if you're thinking about where do you start, how do you start, you can start at the patient level And I like looking at the different areas of the social ecological models out there to determine where the lowest and the highest models that pharmacists can work in. And at the patient level, again, there's a lot of people already doing this, but doing culturally sensitive patient education. All of us, I think, do something with medication affordability and then medication adherence as well. And then in the overall practice, what is the role of the pharmacist in primary prevention strategies? What is the role in social needs screenings and referrals? That's a little bit what I would say more novel and newer to pharmacists. And then the role of interdisciplinary collaboration. And I know we've been doing interdisciplinary collaboration for years, but what does that look like in addressing social and structural determinants of health? And then ultimately in the community level, how should pharmacists be engaged in their community? What are those needs assessments and political advocacy? And this is where you want to get at to how can we go ahead and advocate for changes on the higher levels for patients so that we can address those core structural issues. We've integrated some of these concepts into our practice site. I will tell you, our pharmacy team is pretty good at doing the practice and the patient ones. At the community level, it's really our clinic, and I'll talk about that a little bit later on how they do that and how we advocate for patients at like a health systems level. So what does our clinic look like? The clinic is a federally qualified health center, and I will be upfront that we have way more resources than a lot of clinics probably traditionally have. This practice site, I was familiar with it. I've been in Buffalo for almost 20 years, and I was familiar with it when I first got here. And I believe there was only one site at the time when I first was in Buffalo. And there are now 5 different clinics within our federally qualified health center, in addition to a home health service where we go into patients' homes to see those patients as well. And so there's a lot of opportunity. Each clinic sits in a different area in Buffalo, and so the patient population varies, and it's extremely different from one to the other, although resources are shared across all clinic sites. And so that's one thing to consider when you're sort of structuring services and needs throughout the city. We also recently, and this was within the last 2 years, have developed some community pharmacies within our practice sites. So we have 2 community pharmacies that are 340B programs who also do delivery and compliance packaging. So as I'm talking, I'm sure you're trying to think about ways in which some of those SDOHs I've already talked about are being addressed. And then we have a lot of additional services that traditional ambulatory care clinics and even large health care systems either don't have or maybe don't use as heavily. I've come from a disproportionate share hospital prior to this, so I've always worked in patient populations that needed additional services. But this is one area where all the additional services are really closely integrated to the patients, and there's a really strong interdisciplinary team. We have language services, both in person and also via phone. And that was a great way to engage the community. A lot of the patients who serve as translators work at our clinic or were brought up through, were patients there and then stayed on and were able to provide interpreting services there. We do have a small community healthcare worker program, which those of you that follow community health workers, there's a large initiative going on through some of the New York State waivers to improve community health workers or their roles in healthcare. And so this is an area that will continue to expand. I'm pretty confident in healthcare that we underutilize, well, I would say in the US. We do have an on-site dietitian, an on-site gym, a spiritual care team, some doula services. We do have financial assistance and a whole slew of assimilation services. And this is likely, you know, as well because of the status of us being a quote unquote a refugee clinic. In addition to our practice site, this gives you an idea how large our practice site is. We see about 25,000 patients each year. Total number of visits is almost 87,000. We have a fairly young population where the vast majority of our patients are middle-aged, but we have a very, very large pediatric population as well. My area and my colleagues' area, we're predominantly working with the adult populations. And we see a wide range of races with a large percentage of Asian or Black or African races. And so you see there, 53% of our patients are best served in a language other than English. And so you'll see the wide variation. I would say overall, based on the tracking of our pharmacy services, our clinic closely parallels this general population at our pharmacy consultation service. The one exception to this is we tend to, in our pharmacy consultation service, which you can imagine why, we tend to see higher numbers of non-English speaking patients. Although it says there are 47% of our clinic, their primary language is English. In ours, we don't have that many English speaking patients in our consultation service. So that's important to know. And it's an important aspect for us to know as we're seeing patients to kind of determine what educational skills we might need or language services we need for pharmacy services. I like to talk about how it takes a village. My roots are in global health, and I always think about this when you're doing anything internationally, but even like in social determinants of health. I really truly believe this. It takes a lot of people. This is something that I can't underestimate, that I've never had to more heavily utilize my colleagues across the board at our clinic. I think everybody at our clinic is used to relying on each other, so it's a great place to be, but you really need a large interprofessional team to address social determinants of health. I don't think, based on the fact that most of us are still doing pharmacy roles as well, that there is a lot that can go on in a practice setting that you definitely need your village, I would say. I'd like to say our team is very strong. We have sustained support. That the first person there is Karen Dan. She's the director of pharmacy, who has given us so much support and leeway to structure pharmacy services at the clinic how we would like to, with input, and I'll talk how we did that. We have great support from our chief medical officer, Dr. Elena Krolinkowski. And then there's my co-partner on the far right. Her name is Christine Cachet. She is former student of ours, working with me at the clinic, and is ambulatory care trained. And without her, we could not do the work we do by ourselves. And then I also like to acknowledge, we had a postdoc, and I think this is also important too. Her name's Yael Marks. She just left us after 2 years of a fellowship. She helped us get started in our SDOH roles here at the clinic, and really navigating some of the research and integration of clinical services. And so you'll hear me talk a lot about using learners and things like that in the presentation. So what did we do at our clinic? There were pharmacy services at our clinic prior to us coming here, clinical pharmacy services, but there was a transition, and they kind of gave us the opportunity to review and adapt what was happening to what we would envision as an ambulatory care model. So myself and Dr. Cachet, we spent 3 months orienting to the clinic sites. We shadowed at all 5 different clinics, all the different providers, met with everybody that you can imagine that we've sort of talked about to determine what the needs were of the clinic. So we overall did a thorough needs assessment. And then we developed a service formulation, presented it to both the leadership team, got some feedback on that, and then ultimately presented to our medical providers and how we were going to collect metrics, and then how we were going to integrate learners. At this time, learners were there occasionally. My main position is I'm a clinical professor at UB, so of course we're going to have students integrated there upon us going there. So what was decided was that we would have a pharmacotherapy consult service run 4 to 5 days a week, where we'd have 2 to 3 faculty and trainees. We focus on 3, we call them 3 buckets: clinical services, where we see consults that are requested to us and sent to us by providers. And we do assist in population health measures, the UDS measures, particularly diabetes and hypertension. Although there are a couple other, we just honestly, there's more work than we can probably do at this point, because we're so engaged, and gratefully so, at the clinic. We also do triage consultations and drug information questions. We have both ambulatory APPEs and IPPEs, so 4th and 3rd year students. And then we have had first, 2nd year residents, some clinical fellows, and I'm engaged in some international programs. So we do have some international people shadowing at our clinics as well. And then finally, the other thing that was requested is that we lead some research projects. And so we do a lot of trainee projects, whether it's QI, QA, or other projects. But we always make sure to get buy-in to make sure it is a need of the clinic, and that will help to progress the needs of the clinic and the patients that we're servicing. So what did our role? We've been there almost about less than a year, I would say, and as of January of, I think, maybe July, we've seen 359 patient consults over 5 months, 230 patients, 65 triages, 60 UDSs, and 44 curbside consults. Our main consultations at our clinic are for, as you can see here, medication reviews or patient education. And again, as you recall, a lot of our patients are non-English speaking patients, so that's part of this as well. We do a lot of disease management. This has probably picked up since integration of our services. We now oversee some diabetes protocols where we're doing a lot of insulin titrations and seeing patients a little bit faster between visits for providers as well. And we do a fair number of adherence visits. And so these are some things to think about. Our largest diseases that we address are diabetes and hypertension as well, which fits with our area of expertise. We do a lot with device trainings and teachings as well. And at the time, when you're looking at the social and behavioral barriers addressed, these were based on what we could accrue from our data we were collecting. So these were not studied up front. So we weren't necessarily looking at social behavioral. We were looking just to see what were the patients we were seeing, what languages they speak, what interventions are we making, just to kind of capture what our needs would be that we didn't have. So part of this is we've been trying to make educational materials as well at the clinics that suit the patients that we're seeing, particularly those patients with different language or numeracy issues as well. So although these look a lot like just they're predominantly language focused, we begin structuring these so we can capture exactly what social and behavioral barriers we're addressing, and how we need to move those forward, or how we can be of assistance at the clinic. This was another project that was funded over the last 2 years. We had a New York State ACCP funded project to address hypertension control at our clinic. And part of this was this education poster that we were able to get translated in, I think it was 5 different languages. And there was some dietary counseling that we were able to use our dietitian on to help us. And these posters now will be implemented through all 5 of our clinics, depending on what languages that we need to help them understand and educate patients on hypertension and how to control their hypertension from a patient care perspective. And so this has been a project that, again, we're pretty proud of, because it took us like almost a year and a half to get through this, and we've only been at the clinic a little bit over that time as well with a postdoc. Some of you may be aware, too, that there are new training standards out there for both students and also residents. And so what we were thinking about is, and I teach some of this stuff based on my introduction. So I always think about, okay, we teach a lot about health disparities in the curriculum, but what we don't teach, and what is becoming very obvious, is we're not teaching pharmacy students and even pharmacists that are out there on how to navigate these cultural barriers. You can maybe recognize them, but how do you navigate them? And then how do you impact those structural issues as well? And so our new accreditation standards that are coming, that have been approved in 2025, now highlight both mitigating them, but also navigating them. And then they added the structural factor. So this is a huge lift. I think it's going to be very important, particularly as we see the role of the pharmacist evolve over the next couple decades to addressing social issues and needing to be involved in a team that addresses these issues. I will tell you up front, as I get to in a second, I have students that want to come to our clinic, that know our clinic, so they're very culturally aware, and they still struggle with navigating these issues and sometimes even recognizing them. The ASHP residency standards have incorporated cultural competency and social determinants of health, and do call for addressing and resolving these barriers as well. So again, more active formulation of these problems, and not just recognizing. So that's important. So what did we do? We looked at these different subdomains. We mapped them all to different things that we thought our students needed coming to our site. So some of the stuff our students need, and they've told us this, is they need to learn how to work with an interpreter. They get taught it in school. I teach it. They don't remember it. It's years later. And then even our students that speak second languages always say that's one of their biggest issues coming to our clinic is learning how to use an interpreter, navigating language line, or an in-house interpreter. Our counseling, we do a lot of the basic nutritional counseling if patients don't want to go to see the nutritionist. So our students have to be a little bit versed on cultural nutrition, which again, we were fortunate. We worked with our dietitian to sort of address how that's done. We review all of our clinic resources. In Western New York, we have a website called Western New York 211, and that one links all the social and behavior, like social needs resources in the area that we can go on to see what needs we might have. And honestly, we just have a great navigation team at our clinic that if a patient has an economic issue and I'm not the person for that, I can triage somebody and ask for assistance. And then we do some internal training with them. And then we addressed all these through different applications. Where are these students going to be able to assess these subdomains? How do we need to train them? And where are we going to make sure that they're actually being taught? And these are all applications that are things that myself and my partner would do. So there is nothing here that is extra work for the student. They're doing things that we would have to do normally if the students weren't there. So it's real-time training. So what do we do when the students come in? We give them all these resources. We spend a whole day orienting them on social and structural determinants of health. We talk about, we do a lot of one-on-one counseling. So part of that is talking to the students about how to communicate with patients. It's gotten a little bit crazier in the last couple of years post-COVID, and we try to talk to them about using the LEARN models or patient explanatory models, not just assuming patient groups and stereotyping them, but asking the right questions to get at the core causes that patients are not doing certain things with. The students do pre-chart and do pre-discussions, and we do talk about social determinants of health. These are similar to the therapeutic discussions I used to hold with my students, but now we talk about social issues. What do you think could come up? What are you going to do if that social issue comes up? The student does shadow for the first week of our patient visits, and then at the end of their 6 weeks, because our blocks are 6 weeks long, the students, if they are able to, are leading all of our patient care visits with us in attendance. And then we are reviewing and having our students document on all their SDOHs and then evaluating them as well, separately from our standard our standard evaluations. And we're available at all times because again, we've noticed students are not as well versed in identifying and knowing how to address these. And so we're trying to capture some of that now. So as they go out into practice, they can be the next generation that can help to expand this work that we're doing as pharmacists. Where have we looked at how to address and what interventions we want? Well, we took this work from Chris and Dave. Again, like I said, I work with both of them, but they've done a nice job of determining like what parameters and what are some services pharmacists can do. And we went through these and discussed, are these important to our needs that our patients have? Are these issues that our patients have? And we've talked to our medical team about it as well. And so we've developed like some common interventions that we feel as a pharmacy team we can address. And I think this is important because I'm going to talk on the next slide real quickly about some of these limitations, because although this sounds like we're doing a whole lot in regards to social determinants of health, yes, we're doing more. There are a lot of limitations to how you can integrate this into the workflow of your clinic. And so some of this, and this was the thing that we had discussed at a long time. I know there's a lot of roles for pharmacists potentially in leading social determinants of health and screenings. That was not going to be a possibility at our practice site. We do have a way, we have a lot more social data in our charts compared to other, I think, institutions I've been at because of the nature of the patients we serve. And we are going to more of a structured CMS screening tool. But my job is still to see patients. And so I still need to address their pharmacotherapeutic issues. We're busy. We see patients in 30-minute time slots. And so we needed something where we could address social issues quickly. And unfortunately, a lot of the standard measures, even if they're short, one, they're predominantly in English. Some you can get in Spanish. But again, those are not even some of our main languages. And so they aren't going to work in a busy practice site where we still have other things that we need to consider. We don't get reimbursed. It's part of our service model. That's not true everywhere else, but I will bring that up. We've talked about utilizing those Z codes for reimbursement. We're not quite there yet, but it is at least something that we've been discussing. We talk to the students about like trigger questions, looking at signs of concern, like so there's those signs of health literacy concerns. So that's something to keep in mind. The other thing is we are a consult service. So we see patients that are referred to us. So we're only impacting a small number of patients. It's not widespread throughout the whole clinic. That would take a lot of manpower, particularly at 5 different clinic sites. But I like to think we're seeing patients that the providers feel are difficult to control and they're having ongoing issues with. And we are trying to track that as well. We do have an integrated pharmacy service, which I love. It's very easy, particularly with some of the language issues we have and some of the transportation issues we have. It's very helpful to be able to utilize our pharmacy to know where things are at, have patients pick things up when they need to come in and see us. So, and having a 340B pharmacy, all of this helps. One thing we don't have that other clinics probably have is we don't have a lot of access issues at our clinic. So most of our patients have insurance. So that's helpful. And again, so we don't spend as much time on formulary alternatives or other things like that that other clinics probably can. We're always thinking about one size doesn't fit all. Even amongst our cultural groups, we are tracking what we're seeing and what our themes, but again, we notice even amongst our different patients, it's very individualized. And so we are really trying to teach students and be careful with our communication on how we don't one size or stereotype a different group, and how do we develop materials for linguistic purposes as well. Our learners are all different and their communication skills vary greatly. And so we need to figure out how we can provide better communication skills to navigate social and structural determinants of health, because it's a very complex situation, and sometimes how questions are asked can lead to issues. So that's something to keep in mind. And I will tell you, even within our practice site, many practicing pharmacists are not well versed on how to handle these scenarios as well. And so how do we move that forward? And with that, and I know I went a little fast, I was getting close to time. We will take questions at the end of the presentation. So I appreciate your time and attention. Thank you.
Thank you, Gina. That was a great presentation. And our next speakers, I believe, are Sarah and Jennifer.
Yes, that's correct, Kim. Thank you.
Okay. So looking forward to your talk as well. But just while you're getting ready, this is really an exciting time to be a pharmacist. And I'm so glad we're recording this so that we can share it widely.
I just want to verify, because I know we had some issues with that before. Is this showing in the correct view?
You look good to go.
Okay, great. Thank you so much. So welcome, everyone, and thanks so much again for the introduction, Kim. I am Sarah Amring, and we'll be presenting with Jennifer Travato. We're going to talk a little bit about improving access to medications for our patients in a safety net primary care practice. Neither of us have anything to disclose or any conflicts of interest regarding any of the materials. But what we'll really kind of focus on is some of the barriers that we encountered to our pharmacy services for our patients in an urban suburban setting. We'll describe some innovative services that we have implemented that combine comprehensive medication management with outpatient medication management services in a single site to decrease those barriers to access and increase patient adherence. We'll talk a little bit about some preliminary data on medication adherence and access to care and patient satisfaction, and talk a little bit about how we're planning to expand some of these services for our patients. And so to kind of transition and what we found, so our first service that we implemented was actually comprehensive medication management within the primary care setting. And right off the bat, what happened was one of the closest pharmacies for our patients closed. And so we found very quickly that there were some issues with patients accessing medications. Many of our patients, as we'll talk about, have transportation issues and some other barriers. And so we see this happening across the United States, and it's becoming a larger issue. In fact, just recently, I believe many of the large chains have either reduced operations or are closing various stores. And so when we started to kind of look into some of the issues, what we saw, this isn't necessarily a unique problem to Rochester. And what we wanted to determine is, what does this look like? Is this a problem everywhere, or is it really maybe just facing our issue? And we found some conflicting information, which was really interesting. Gudemuth and colleagues in a recent study noted that overall there are fewer pharmacies per capita in neighborhoods of color based on census data. And so you can see that for our Black and Hispanic Latino patients, that there are generally fewer pharmacies, while the numbers were increasing overall. The general concept was that we had fewer pharmacies per capita. However, more recently, there is some information published by Surrey, and it noted that in New York State, they're actually, for our patients in disadvantaged groups, so that was both by income, education, and race or ethnicity, that there actually was improved access to pharmacies in the majority of areas. And so our patients who were white, higher educated and higher income tended to actually have lower access to pharmacy. However, when they started to drill into this even more, what they found was that zip code and individual zip code and small area data was conflicting. And so just as a point of reference, when we start looking at Rochester and the Metro Rochester area, which is the shaded area that you can see, the population is about 750,000, which puts us on par with some of the smaller cities such as Memphis or El Paso. And so you can see some of the comparable cities that are in that area. And when we start to look at our larger cities, New York, San Francisco, Boston, et cetera, there's actually a smaller disparity in our pharmacy locations per capita. So we actually tend to see that those larger cities, we have a higher density of pharmacy access. Patients are able to access them easier. We also are pretty well aware that in those larger cities, much higher access to public transportation, a much higher infrastructure system for our patients in terms of accessing areas or having to travel. And we start to see that there's a larger disparity in our smaller cities. The infrastructure is less. Public transportation may not be funded or put into practice as robustly as some of our larger cities. So when we really started to drill into Rochester specifically, what we started to see is in this area, and so this little circle here is actually where our clinic is located. This is a really great tool by the AP Press that they put together in terms of accessing pharmacies, which we thought was really interesting. And so for these zip codes, we see these are majority of the zip codes that are actually servicing our patients from our area that are coming to our clinic, that they do actually have a smaller or less access to pharmacy services for our patient population. And so we started to realize that need very quickly. In addition to just access to pharmacy services, I think we can all appreciate that the majority of patients who are utilizing a safety net practice or are in an urban area, many of whom are presenting with, as Gina just pointed out beautifully, a lot of social determinant of health burden, whether that's education, income, and access to general services. And so what we started to see again was this sort of administrative burden. So our patients would present with a barrier. And so administrative burden really being defined as those administrative tasks related to healthcare, such as prior authorizations, rescheduling appointments, navigating the healthcare system, and referrals. And so for our patients who have lower baseline health literacy, education deficits in general, we started to see that those tasks are reported as more of a burden. So for those who have a family income below 138% the federal poverty limit, and those who have public insurance found that those tasks were much more burdensome than those who had higher income. And so we noted that with our patients that even though we could write a prescription and they had access to a pharmacy and they technically could get there, if there was any sort of barrier, we started to find that our patients were not able to access their medications appropriately. The American Medical Association definitely has been quite vocal about their, I guess, distaste of prior authorizations, and have noted that we actually see patients not receiving care or abandoning treatment because of these barriers. The PAN survey also noted that half of insured adults noted their insurance required a PA, and 2/3 of patients noted that this delayed their access to their medication. And the average delay was about 2 weeks. For a patient who's needing something like insulin or a life-saving medication for heart failure or hypertension, this could be a significant issue and result in patient harm. The Kaiser Family Foundation noted that 1 in 4 patients with Medicaid experience problems with prior authorization, compared to 1 in 10 for those who have Medicare, or 1 in about 12 for those who have employer-sponsored coverage. So again, some pretty significant literacy and social barriers for our patients in terms of accessing medications, and not just actually getting to the pharmacy, but then finally being able to actually get their medication. And finally, what we did notice is a lot of our patients they work. And so we see pharmacies in our area that are reducing their hours. And so this has actually been brought up to us multiple times, where patients say, I tried to go to my pharmacy, but they were closed today. I tried to get there and they're not open on the weekends, and I have to work during the week. So I don't really know what I'm supposed to do. And for many of our patients, again, we can see that being able to access those services are pretty significant. So all of these are hours of pharmacies that are within walking distance to our clinic, and many of which our patients tried to service or utilize. So Manhattan Square Family Medicine is a safety net practice, one of approximately 40 clinics within the URMC primary care network. So as a safety net practice, at least 35% of our patient volume are associated with Medicaid, they're uninsured or are dual eligible. That does provide us some increased access to services for our patients. We do have 7 providers, 6 physicians and 1 physician assistant. We have 1 primary care pharmacist and 1 medication management pharmacist within the site. We have a full-time nurse care manager, a behavioral health therapist, 2 home care managers that help our patients navigate their home care needs, 2 registered nurses on site, and then a plethora of staff that are amazing and help us navigate all of these situations with our patients. On-site services include family medicine, so we do see pediatrics and adults. We do have a laboratory on site, however, it is only open part-time. We have emergency food supplies, so patients who are identified as food insecure can access food bags. It is mostly highly processed and not necessarily the best option, but it's a food service for our patients that are having difficulty. We do have behavioral therapy, gender affirming care, diabetic eye screenings, and a smattering of other specialty services, including an orthopedist who stops in once a week. In terms of our payer mix, the majority of our patients are Medicaid, Medicare, and also Excelis or commercial patients. And for most of our patients, the data is from August. It really does represent most of our patient population fairly clearly. Our patients are right about middle age, so 27 to 54 on average. 5.6 of them speak a language other than English, primarily Spanish. However, we do have some other populations as well. 24% identify as Black or African American, and 12% identifying as Latino, Latina. 6.7% of our population is LGBTQI+. And so again, we have a very diverse population within our site, and with a diverse set of needs. And especially as we expand our medication services, we're finding that a lot of our patients do need a little bit more than just access to meds. So 44% of our patients live within 1 mile of our clinic, and 56% live within 5 miles. The majority of our patients are utilizing public transportation or walking in order to access care. And most of our patients identify as having an income below federal poverty limits. So in terms of the services that we started with a comprehensive medication management pharmacist at part-time about 2 years ago. Very quickly progressed to moving to a full-time site. The CDTM was put into place in May of 2023, and that CDTM, as I'll describe in a moment, covered a variety of disease states. The comprehensive medication management pharmacist moved to full-time in July, and we added our medication management as a pilot program to help our patients access pharmacy services at the same time. In August of 2023, we initiated a population health initiative surrounding diabetes, so pulling in patients with uncontrolled diabetes as defined with A1Cs greater than 9, and started to proactively reach out to those patients. And then we became the PGY2 AmCare residency longitudinal site in July of 2024, so adding to our arsenal of pharmacists available. In terms of CMM services, so comprehensive medication management, just as a refresher, we're identifying patients, we're identifying whether the patients are taking the appropriate medication for their condition. Is it dosed adequately to control it? Is the patient able to adhere to the medication that is provided for them? And is it safe for them to take? So we do that for any patients with uncontrolled chronic conditions, recent hospitalizations, identified as polypharmacy, and we have a ranking score that we utilize for that, or patients presenting with a new diagnosis or new chronic disease. Currently, the CMM pharmacist myself, I work at 0.7 FTEs for direct patient care, which is provided telemed, in-person, 20 or 40-minute visits, depending on the reason for visit. Majority are physician referral. However, we do have the diabetes population health running in the background that feeds into some of our volume. And I have full administrative and clinical support. So my patients are scheduled for me, and my patients are roomed when they come to visit in person. Our CDTM allows us to adjust or discontinue medications for conditions such as asthma, COPD, diabetes, heart failure, hyperlipidemia, hypertension, tobacco use disorder, and is currently being expanded as we speak to include several more chronic conditions, and then continue to push into some of our more uncontrolled areas and physician support services. So since we moved into this space as just the clinical pharmacy service, in terms of patients with an A1C less than 7, we started at about 52.4%, and we are currently at 73.5%. Our patients with hypertension, blood as defined by a blood pressure less than 140, we started at around 59.7%, and we're currently at 64.2%. And so these are all patients that are managed directly by the clinical pharmacist. And then encounters in general, we started around, for the first year, we had about 159 patients and 382 encounters. We now have seen 690 separate patients within the CMM service, and we've conducted 1,400 encounters for patients. So we've grown substantially. We've been fully integrated and adopted within the site. And at this point, again, as we were navigating this, we needed to find a better way to access services for our patients. So I'm going to turn it over to my colleague, Jenny, who's going to dig into a little bit more our medication management services and how we could basically push our patients into a better state of health by removing all those barriers. So Jenny, I'll advance your slides whenever you let me know.
Thank you, Sarah. So you can go ahead to the next one. The medication management program was started by URMC back in, I would say, 2022, so just a couple years ago, and only managing about 500 or so patients at the time, and it was all performed off-site at a central location. And we still have that central service, but we now are covering so many more patients. So what we do just in general is that adherence calls for these patients are made 7 days prior to their medication due date. And at that time, we are getting refill requests, performing prior authorizations. So that's all taken off the patient's plate. If they need their adherence packaging, which I'll show the different types of examples of that, this is all done at the central services location. Once we've reached the patient and confirmed delivery or pickup with them, if they are picking up at the pharmacy, we then will route the request to the strong outpatient pharmacy. The prescriptions are filled overnight because the pharmacy is open 24/7, which is great for patients. They can come whatever works best for them. You know, if they work nights, if they work days, whatever their ideal is, if they choose pickup. But either way, prescriptions are filled overnight and set for delivery the next day. Our U of R courier service will then pick up the medication from the pharmacy, bring it to the patient, and all of our deliveries are tracked. And then once that delivery goes out, their next refill is scheduled and the cycle continues, so to speak. Our courier service will service all of, Rochester and wider area, but we can FedEx literally anywhere. Just might take a day or two longer for FedEx, but they are great. We can put notes for the courier if it's leave at the back door, leave at the side door, whatever the patient prefers. But they do like having that, personal service for the delivery and seeing the little U of R driver coming to their home. So yeah, now we're managing about 1,400 patients and moving from just this central offsite to embedding these medication management pharmacists within the primary care network and primary care service. So if you would like to advance to the next slide, please, Sarah. Thank you. So the embedded medication management pharmacists are the primary point of contact for the outpatient pharmacy services. So we are the ones that the outpatient pharmacy service will reach out to if there's an issue. They are unable to reach a patient. Maybe the patient has been lost to follow-up. They might say, hey, this patient has an appointment with their PCP or the clinical pharmacist. Are you able to meet with them? Is this something that you can tag into? Absolutely. I'll run in the room and see what we can do to get them back on track. We are also the go-to person for new enrollments for patients within the clinic. So whether it's an adherence issue, patients that just, would like the delivery, or if it's more of a complex patient. So transition of care coming out of the hospital, medications are changing, or like we spoke about, not adherence. These are example of our two different types of med packing. The one on the left here is the disc fill, or more of a manual med pack, which is what we used to have, and we still do, but the medications are blister packed, up to 4 times daily dosing, as shown in this example here. And it's all packed manually by the pharmacist at the central services location. The other example is the Parata med box, where the medications are in little tear-off pouches for the time of day, similar to like the Amazon pill pack or something more like that, which patients seem to gravitate towards more. And we use that for most patients, unless they have trouble with it, whether it's dexterity or a visual issue, then we will use the manual med pack. So whatever works better for them, we have different options. And these are always available for patients. There's no charge for any of these services. So we currently have 4 primary care practices with both medication management pharmacists and clinical pharmacists, like Sarah and myself, both on site, and currently, expanding to more. But this is an example of how we are, integrating in this location. So if you want to go to the next slide. So other than getting referrals from PCP and clinical pharmacists such as Sarah, the medication management pharmacist's daily workflow, we will actively identify patients with adherence gaps and barriers. such as those social determinants of health, like transportation issues that are documented in their e-record, whether it's at their last, visit, they were noted to have barriers coming to the clinic, medication cost issues or food insecurity. So these would be a reason that we might want to tag in to see this patient. And then after seeing the patient, also send a message to care manager or social work to address any issues and all work collaboratively for the patient. For patients with complex regimens or medication regimens, performing a medication reconciliation to simplify their med list and see, what exactly are you taking? Bring in all your medications. Let's go through them together and see when was the last time you filled everything. Does this make sense? What are we missing here? And then is adherence packaging, is that necessary? Do you think that this would be helpful for you? And then also mapping their adherence packaging. So what time of day do you take your medications? Where should we put your meds in your med pack that makes sense for you, so that not only, what will work best so that you will remember to take your medications and have the best outcomes for you. And then also coordination of care with outside providers in different systems. So for example, we're URMC, but also Rochester Regional Health. We have many patients with that see Rochester Regional, like cardiology or dermatology, reaching out to them to get prescriptions. And even as far as I've had patients that are in the medication management program, but they're transplant patients from the Cleveland Clinic. So coordinating with the Cleveland Clinic to get medications, and if there's medication changes post, if it was discharge or meds changing because of labs, things like that, it's important to stay on top of all of those transitions of care. And then also for just new enrollments in general, coordinating if the patient needs any same-day deliveries for acute medications and working with the RU of our couriers and dispatching to them the urgency and with the outpatient pharmacy to get those medications filled and out to the patient as soon as possible. So is there anything that you need today? If not, let me get everything sent over, and then we'll work through and set up, when your next pill pack can be out to you, or if we're just going to synchronize everything and get it out to you at the same time. If there are cost issues for the patient, and that's their biggest barrier, we will look into manufacturer coupons, formulary issues, maybe getting a different covered alternative for the patient. Prior authorizations have been huge. I don't know how many I initiate in a day. I can't even keep track, but prior authorizations seem to be the biggest barrier for patients not even being able to get medication. And they may not even communicate that with the clinic, that, I didn't get it. I wasn't able to get it, and I don't know why. We also work closely with social work. So social work may be able to provide vouchers for copay assistance. So if it's even as something as big as a Medicare deductible, if it's preventing the patient from being able to get their medication, it's something that, we can look into. We never want the patient to be without medication, and we will do everything that we can to help resolve any issue for them. So once these issues are addressed, they're enrolled, they're set up, we get their med pack, everything is good to go, so to speak, then those maintenance fills are handled offsite at the central services location for moving forward. You can go to the next slide, sir. So this is just an example of how much we have grown. So looking at PDC, or percent days covered. So as a measurement of adherence, back in 2023, we were at 58 up to 63 for external pharmacies. So even though we are primarily working with the Strong and URMC pharmacy, we still have an impact, with CMM and Sarah, Within the clinic, we have grown about 5%. Within SMH pharmacy specifically, we are hitting now about that 80% mark, which is that standard for CMS. It's about 80% for star rating on PDC. And like I have said before, the number of patients in the program have grown from about 500 to almost tripled up to 1,400. And I think the last time I checked, the PDC from the end of this month was about 86%. You can go ahead. This is just an example of some feedback we've received of patients. I won't read all of these, but just saying that they enjoy their med box or they're no longer confused about their medications. We are in the process of getting a formal survey out to patients. So once we have that, it will be nice to have actual feedback on how the program is going, but the verbal feedback, it is nice to hear how the patients are doing. And then for our future direction, we are conducting a retrospective study within the resident program, evaluating the effect of the URMC medication management program, PDC and adherence rates and clinical outcomes, specifically PDC on specific classes of medications, comparing pre and post enrollment within the program. We're also evaluating the relationship between PDC and clinical outcomes such as hemoglobin A1C, blood pressure, and LDL. Our hope is that with the results of this study, we can be used to further grow medication management services and the need for collaboration between the clinical and community-based pharmacists in the outpatient setting, and further, help grow these expansions. So right now we're at 17 primary care sites. There's at least one pharmacist, whether it's a medication management pharmacist or a CMM pharmacist. 4 have both, but we would like to continue to grow and expand into rural areas with telemed, and even offer a 24/7 same-day delivery with our U of R courier. So right now our pharmacy is open 24/7, but our courier is only offering delivery Monday through Friday. So I know that we are working on some Saturday deliveries coming up soon, hopefully. But these are all things that are in the works. So if we continue to advocate and have results maybe from this study and moving forward, we can continue to grow within the program. So thank you so much for listening today, and be happy to take any questions at the end of all the presentations.
Well, thank you so much, Jennifer and Sarah. Great things are happening in Rochester as well. So yeah, definitely looking forward to the Q&A part. So our next speaker is Hanlon Lee and Amber Bradley on pharmacoequity and postpartum hypertension remote monitoring.
Thanks everybody for taking the time to join tonight. My name is Hanlon, and I'm here tonight with one of my colleagues, Amber, to present our experiences for our program focused on postpartum hypertension RPM. First and foremost, we have nothing to disclose for today's presentation. Our objectives for today include to describe disparities in postpartum hypertension care, design a pharmacist-integrated RPM program, and exactly on the process of what we utilized to implement our program. And lastly, evaluate the impact on pharmacoequity and future directions. First, I would like to go through some of the pertinent background information to really help us set the stage. Pharmacoequity is defined as to ensure equal access to high-quality medications for all individuals, regardless of race, ethnicity, socioeconomic status, or availability of resources, to effectively manage their health needs. And I hope by this point of the presentation, you have started to appreciate the role of a pharmacist in driving pharmacoequity and really closing some of these gaps. And we will share our experiences related to the postpartum patient population. That brings us to our first assessment question, which is what percentage of patients do you think attend at least one postpartum visit? A, 90%, B, 80%, C, 70%, and D, 60%. I'll give everyone about 30 seconds or so to answer. Okay, so the correct answer for this question is letter D, 60%, which, as you can see, is the lowest amongst the answer choices. As we dive into some of the literatures, again, really showcasing and highlighting, there is quite a bit of disparity in care in this particular patient population. Approximately 40% of patients do not attend a postpartum visit altogether, whereas 50% of postpartum strokes occur within 10 days of discharge. So that shows the sort of the most vulnerable period for some of these complications is the immediate post-discharge timeframe. And additionally, looking at our Black and Hispanic women who have shown to access care less frequently than those of their white counterparts. And this is largely due to, again, some of the socioeconomic factors that we typically see, including different insurance statuses, access to care, access to resources, and etc. Maternal mortality rate in Black women is the highest among any racial group in the United States. To the right of the slide is a screenshot of an article published in the Times, basically illustrating that the most dangerous time after the mom comes home is largely due to most of the attention goes to the newborn. There's very little attention to the mom themselves, or sometimes the health may be overlooked. And this is really a crucial period where we can intervene and make an impact for our patients. Looking at complications related to pregnancy, hypertensive disorders contribute to about 10% of the pregnancy can be complicated due to this particular group of diseases. It is a significant driver of maternal morbidity and mortality. It's also the leading cause of postpartum readmissions. Looking at the different types of hypertensive disorders of pregnancy, we have chronic hypertension, which is defined as if the hypertension was detected pre-pregnancy. So this is totally unrelated to the pregnancy. The patient has always had hypertension, or if it was detected before 20 weeks of pregnancy. Gestational hypertension is defined as if it was detected after 20 weeks of pregnancy. Preeclampsia, also known as PEC, with or without severe features, are two additional types. Examples of severe features include patients who have severe hypertension, such as a systolic of equal to or greater than 160, or diastolic equal to or greater than 110 on 2+ occasions, or an organ dysfunction. Another type that we commonly see as referral reason is superimposed preeclampsia or superimposed PEC. This is when PEC occurs in a patient with a history of chronic hypertension. As a result of what we have seen in literature of the disparities in this patient population. They are national and state initiatives to really increase awareness around this area, such as a policy statement from the American Heart Association, as well as locally within New York State. We really try to prioritize maternal health with expansion of Medicaid, prenatal and postnatal benefits. Our second assessment question is, according to the American College of Obstetricians and Gynecologists in patients with hypertensive disorders of pregnancy, blood pressure should be monitored for the immediate 72 hours postpartum, and again within A, 7 to 10 days, B, 14 days, and C, 21 days, or D, 28 days. All right, so the correct answer here is A, 7 to 10 days. So again, blood pressure should be monitored within 72 hours for severe hypertension, and again, within 7 to 10 days postpartum for all patients with hypertensive disorders of pregnancy. A couple of key takeaways from the background section is that postpartum period is an especially high-risk time for not just our high-risk patients, but also for some of our patients who don't necessarily have risk factors. They are national and state initiatives called to improve maternal health. And again, pharmacists can really play a role to close care gaps for our patient population. And last but not least, ACOG suggests monitoring blood pressure 72 hours postpartum, and again, within really the first week to 10 days postpartum. Here's a study that looks at improving follow-up by enhancing access to care for postpartum hypertensive patients, which took place not too far from us in Yale New Haven, Connecticut. And the aim was to assess compliance to ACOG follow-up recommendations by incorporating a clinical pharmacist to complete postpartum visits via telehealth. What they saw as their results included 94% of those patients had an appointment with the healthcare provider, so in this case, a clinical pharmacist, within 10 days of discharge, versus 65% of patients in the usual care arm with their typical OB provider. There was a shorter number of days until follow-up in the intervention group versus that of the control group. And their conclusion was that a team-based RPM program leads to improved adherence to recommended follow-up and may allow for opportunities to identify and reduce maternal complications. And with that, I will transition over to Amber to share our program details.
Thank you, Hanlon. So I'm going to go ahead and start off by outlining some of the details of our program that we started. So starting off with the Center for Health Justice that we have at New York Presbyterian. So this center aims to understand and address the root causes of health inequities. They invest in research, education, and programming, and they're looking to build a network of ongoing projects and initiatives across New York Presbyterian. And their more long-term goal is to advocate for policy change to drive measure improvements in health outcomes for all patients. And we really focus on the communities and the patients that we serve at New York Presbyterian. So that brings us specifically to our postpartum RPM program that we have. So we're very fortunate to have received a grant from the Institutional Center for Health Justice at New York Presbyterian. So we've been doing this in collaboration with them. We're looking to mature our existing remote patient monitoring program. The ambulatory care team has been heavily involved in RPM across many of our internal medicine clinics, and these programs have been quite successful and they continue to expand to other clinics. So we're taking that strong RPM foundation that we already have and applying it specifically now to the postpartum population. Our goals for our program are to address key factors that impact maternal morbidity and mortality. And we're really committed to improving equity by providing the same high level of care to all of our patients. And right now we're specifically focusing on our Medicaid and uninsured patients that would have longer wait times for OB appointments at our hospital-based clinics. We're looking to improve blood pressure management and outcomes. And lastly, to help provide connections after our delivery. So if a patient needs a primary care provider or benefit from access to a social worker, we're also helping to facilitate those connections. So this next slide really emphasizes how collaborative our program is. We have a lot of different specialties and departments that have helped launch and contribute to the program. So we have our pharmacists, doctors, physician assistants, nurse practitioners. We also have medical residents, nurses, the Center for Health Justice that we previously mentioned. We have IT that helps create a lot of things on the back end, and then our administrative specialists that help with scheduling our patients. So this is our current workflow for the program. So while the patient is in the hospital for delivery and prior to being discharged from the hospital, their OB provider will place the pharmacy referral. While inpatient, we have the RN provide them with a blood pressure cuff and training on how to properly use that cuff. And then the patient is enrolled in our online patient portal. They're then scheduled to our pharmacy template within 3 to 7 days of discharge. So again, we're really looking for close follow-up. And we've learned that when our patient has that appointment before they actually get discharged from the hospital, they're more likely to attend and be engaged in care with the pharmacy team. When the patient's home, they check their home blood pressure readings and upload these to the patient portal. Those readings then get transmitted to the pharmacy team, and we adjust their medications per our collaborative practice agreement. And follow-up appointments are scheduled anywhere from a day to 1 or 2 weeks later, depending on how their blood pressure is and if we adjusted medications at the visit. And lastly, we do have a workflow in place to refer patients to triage if they have any severe range blood pressure readings or any other emergencies that come up during our virtual visit. So that brings us to question number 3. Which medications are used for postpartum hypertension? Select all that apply. A, labetalol, B, nifedipine, C, enalapril, or D, hydrochlorothiazide. So I'll give everybody just a couple seconds to go ahead and answer the question. So the correct answer is all of these agents. We can use any of these when managing postpartum hypertension. So this slide outlines some of the content that we do have in our collaborative drug therapy management agreement. So under this agreement, we can manage these medications. And this chart does have some of the information, including starting doses of medications, emergency doses, meaning that if we're on a call with a patient and they have an elevated reading during our visit, we can schedule a now or an emergency dose for them to take during that call. And then we also outline titration doses as well. And then when we think about medications in this population, it's also extremely important to mention pharmacoequity and medication access. So these 4 agents that we prescribe are generic. So generally we have not had insurance or affordability issues. But we have noticed that when we're prescribing twice daily nifedipine, occasionally based on the patient's insurance, it will require a prior authorization. So if needed, we'll complete those for our patients so that they can receive it in a timely manner. Sometimes after discharge, we'll have our initial visit 2 or 3 days later, and some of these new moms have not had a chance to pick up their medications yet. So we'll call pharmacies and inquire about delivery or even help transfer that prescription to a different pharmacy that does offer same-day delivery so that our patients can start these medications as soon as possible. Through our program, we provide validated blood pressure devices free of charge to our patients that are enrolled in the program. And then after graduation, they're able to keep these devices long-term. And then we do have extra large cuffs available if needed. And lastly, I wanted to mention lactation safety. We always let our patients know that these medications are safe to take while breastfeeding their babies. So the next segment of the presentation will focus on successes and opportunities. So this is a timeline dating back to October of last year and really the planning stages. So during that stage, we created a comprehensive standard operating procedure in collaboration with our team and the maternal fetal medicine providers. We have a referral order in the electronic medical record, and then once that's placed, the patient's scheduled directly into our dedicated pharmacy template. We also created a standardized note template that we use to document all of our encounters along with medication changes that we make in the electronic medical record. So moving on to the launch period, which was May of this year, our team attended a 4-hour trauma-informed training session for advanced practice clinicians, and some of the inpatient OB providers also attended this training with us. We officially started accepting referrals at one of our campuses across New York Presbyterian at the end of May, and during this launch period, we averaged about 1 to 2 new referrals per week. Moving on to the observation phase now, we have a steady rate of referrals and we're averaging about 5 to 8 new referrals per week. So we've definitely picked up since the program launched in May. We have weekly meetings scheduled with our maternal fetal medicine providers where we review the patients that the pharmacy team saw that week. And then we also troubleshoot any workflow issues that come up during our encounters and also just during the program. And then we continue to coordinate long-term follow-up at our internal medicine clinic. So if any of our patients do not have a primary care provider and would like to be seen at our clinic for long-term follow-up, we help coordinate that transition to get them a doctor to follow up even in the postpartum period, after the postpartum period. And if our patient is uninsured, we do have an excellent student-run medical clinic at the same practice location where we can refer our uninsured patients as well. And lastly, we have open dialogue to share best practices with the pharmacy team at Yale, who also manages postpartum hypertension. So moving on to our overall impact to date. So this is really from launch, the end of May to the middle of August. So we've had 26 referrals during that time period and 19 patients had their initial visit with the pharmacy team. So we triaged one patient to the emergency room that had severe range blood pressures and symptoms. We'll review that patient a bit more on the next slide. We've adjusted antihypertensives for 43% of the patients that had a pharmacy visit. So this is really showing that many of the patients that we do follow shortly after do need dose adjustments. We've referred 2 patients to the lactation warm line. So during our visits, if something comes up with lactation questions or concerns, we have a workflow to connect them to a lactation specialist. We've connected 1 patient to primary care. This number is higher now, probably around 5 or so. So any of our patients that don't have that primary care provider, we're helping to connect them to long-term follow-up. And in total, we've graduated 8 patients so far, meaning they've been normotensive at least their 6-week postpartum visit with us. And they either were not on medications at the time because we down titrated or discontinued, or they haven't had any recent adjustments. When we're discharging and graduating our patient, we also send a discharge letter summarizing the patient's follow-up during the program to their primary care provider to kind of close the loop and let them know that we're discharging that patient. So next we'll discuss one of the patients that the pharmacy team saw. So at the top of the slide, you can see the patient's demographics listed here. And of note for this patient, a medical interpreter was used during all of our encounters. So this patient was referred to the pharmacy team for chronic hypertension, meaning that even prior to their pregnancy, they had that diagnosis of hypertension. When they were hospitalized and prior to discharge, her blood pressure was very well controlled on labetalol 200 milligrams twice daily and hydrochlorothiazide 12.5 milligrams daily. Her initial visit with the pharmacy team was just 48 hours after discharge. So again, I really just want to emphasize that close follow-up. And at our initial visit, her systolic blood pressure was over 160 on more than 2 occasions. And as Hanlon mentioned, in the postpartum or pregnant patient, this is considered severe range and very dangerous. And then she also presented with a lingering headache. So she had symptoms as well. So we strongly recommended that she come to her local emergency room or come back to the hospital at New York Presbyterian. for evaluation given those really high readings and her symptoms. Originally, the patient declined. She just got home with her baby. She said she couldn't really go to the emergency room at the moment. So we scheduled a now dose for her to take up her labetalol during the call. And then we also increased her scheduled dose. And we let her know we'd call her back in 2 hours to follow up and see how she was feeling after that extra dose of labetalol. We also alerted our maternal fetal medicine providers and the OB team just to let them know that we did recommend that this particular patient come in for evaluation, so she's on their radar if she actually did come in. 2 hours later, we followed up and her blood pressure improved a bit, but she was still having systolics into the 150s, and she had that lingering headache despite taking Tylenol. So again, she was having elevated blood pressures with symptoms, so we strongly recommended evaluation, really emphasized the complications of elevated blood pressure in the postpartum period. And eventually the patient agreed and presented to the hospital at New York Presbyterian. Upon presentation, her systolic was even higher into the 170s and she still had that headache. And ultimately the patient ended up being admitted for rapid blood pressure control. And she received IV push hydralazine and a mag drip as well for seizure prophylaxis. A few days later, the patient was discharged and she's doing well now, but she was discharged with her new diagnosis of superimposed preeclampsia with severe feature. So as Hanlon mentioned, superimposed, meaning she had that history of chronic hypertension before, and the severe features were her very elevated blood pressure with that headache. So we continue to follow up with her after that discharge, and she's doing well with great blood pressure control. But in the last box, I wanted to highlight her medications at her 2-week follow-up with us and really take note of her new regimen. So she's now on labetalol 800 milligrams twice a day. She continues on the hydrochlorothiazide 12.5 milligrams daily and had a newly added nifedipine 30 milligrams daily. You can really see how her regimen was titrated up quite rapidly from delivery to 2 weeks postpartum. And this patient story really just demonstrates how drastically that blood pressure can change during the postpartum period and how critical close follow-up after discharge is. So this patient did have her 2-week OB appointment already scheduled, but this is just a great example of the pharmacy team providing close follow-up after delivery and seeing and speaking to this patient even before that first 2-week OB appointment and potentially preventing complications in this patient. So on this slide, we'll just review one other patient story. So it's the same outline with the patient demographics listed at the top. So this patient was referred to the pharmacy team for preeclampsia with severe features. So her severe features were based off of her elevated systolic blood pressure of over 160, and then she also had abnormal liver enzymes, so also some of that end organ damage. And she was discharged on nifedipine XL 30 milligrams twice daily and furosemide 20 milligrams daily for 2 more days to complete a 5-day course. So I can also mention here that some of our patients are also discharged on furosemide because literature has shown that it leads to a faster resolution of postpartum hypertension. So similar to the previous patient at discharge from the hospital, her blood pressures were well controlled on this regimen. So her initial visit with the pharmacy team was shortly after discharge, but she had not started taking her medications yet, and she had not started checking her blood pressures yet. So during the call, we asked her to sit and check her blood pressure with the machine that we gave her, and it was 155/99 without symptoms. So she did have the medications at home. She just had not started them yet because she was a bit hesitant. So we provided a ton of education on maternal warning signs, when to present to the emergency room, and the risks of uncontrolled blood pressure in the postpartum period, and asked her to start taking her nifedipine. We followed up 2 days and 4 days later, and her blood pressure was still above goal. It was better, but still above goal into the 140s over 90s. She remained asymptomatic, but we realized she was incorrectly taking her nifedipine once daily instead of twice daily. So from there, we reiterated twice daily nifedipine, and then at her 2-week and 3-week follow-up, her blood pressure was at goal of less than 140 over 90. So this is another great example of pharmacy having a follow-up shortly after discharge and capturing this patient that was originally hesitant to take medications. So we were able to provide a lot of education and start medications that day, and we may have prevented her blood pressure readings from increasing even higher into the severe range. Again, this patient also had her 2-week OB appointment, but we were able to speak to her and capture her before that first appointment. So we also wanted to highlight some patient quotes that we have received so far. The first one reads, "I really appreciate the calls because they remind me to keep track of my blood pressures and my health." So often our patients are very busy with their newborn. They just got home and some of them haven't yet had a chance to check their blood pressure. So our calls or our video conferences really remind them to also take care of themselves, where they can check their blood pressure over the phone with us and still get care despite being so busy. The next one reads, "I feel good knowing that when I upload my blood pressure readings, they are being reviewed by my team." So our patients have expressed feeling comforted that when they share those readings, they know that the pharmacy team is reviewing them on a daily basis. So as they upload them, we're reviewing them Monday through Friday, 8 a.m. to 4 p.m. during program hours, and we do have a workflow in place for elevated readings outside of those hours. So the last one reads, "Thank you for helping me find a new primary care doctor. I have been trying to look for a new doctor, but I have been so busy with my baby." So again, we're also able to provide support to our patients outside of just blood pressure management and help connect them to care more long-term. So our team is also looking at measures. So for process measures, we're assuring that our team completes the training, education, and onboarding. We're keeping track of the number of patients who were referred to the pharmacy team, the number of patients who kept that first visit, time to engagement in care. So after that referral is put in, how soon after are they having that original visit with the pharmacy team? We're keeping track of the number of visits each patient utilized, because some of our patients we're talking to multiple times a week, so keeping track of that engagement as well. For outcomes, looking at engagement in care, number of emergency room visits after postpartum discharge, readmissions for severe range blood pressure readings or other severe morbidity. So we're tracking all of this. So that brings us to question number 4. So pharmacists play an integral role in managing blood pressure during the postpartum period and contribute to pharmacoequity in patient care. True or false? So the answer is true. So hopefully we're all now aware of the important role that pharmacists can play in promoting pharmacoequity and providing care during the postpartum period. So going forward, we hired an additional pharmacist for cross coverage. We now provide clinic sessions 5 days a week with available appointments in both the morning and the afternoon sessions. We're continuously looking to increase capacity, and the goal is for all high-risk patients to have a check-in with the pharmacist after discharge. And our real target is to have 30 patients on our monthly panel. Right now, we're live at one of our campuses across New York Presbyterian. More long-term, we'd like to expand to all of our campuses, including other boroughs. And we're also, as we expand, looking into billing for these remote patient monitoring services. And lastly, we'll review those measures that we spoke about, including patient satisfaction, engagement with care, and readmission rates. So thank you all so much for tuning in.
Thank you very much. That was another great presentation, and looking forward to now some good Q&A. Lisa Anzizi put a few questions in the chat. Lisa, are you still on? Do you want to verbally address them, or I'm happy to read them as well? Okay, well, so I'll start with the first question. And I think, Gina, you talked a little bit about this during your presentation. What is training is helpful for using translation services?
Yeah, so we provide upfront. Language Line has like just a general overview on how to use an interpreter. So we provide that up front to all of our trainees at the before they come on site, and have them read through that. And then a lot of it is just having them watch us. So the first week or so, we show them how to use both the phone and the in-person interpreters. And then slowly we just have them do it themselves. And as they're in a room, a lot of times they're not looking at the patient or the interpreter. If they're on the phone, they're looking at the phone. So we'll just kind of navigate and say, hey, can you turn this? Can you do this? We're fortunate our patients are very understanding in our clinic about that. And some of it's just even basic stuff like upfront asking, like what language would you like your session in, confirming language. We have patients that have 3 or 4 languages in the charts, and then double checking on dialects and things like that. So some of that as well we integrate, but we start at least with like the language line. There's a nice, they have a nice overview on how to use them. And if anybody needs them, I can put my email in the chat and you can reach out and ask and I can send it to you as well.
Okay. Sounds like a good idea. Second question is for the entire panel. And for all presenters, are all CDTM pharmacists on site at the practice? Are any patient outreach done at the central location offsite or remotely?
So this is Sarah. I'll jump in. For all of our patients or all of our pharmacists who are CDTM licensed, we are all on site. There is discussion in terms of remote opportunities, but we haven't necessarily broached that. The board has been a little more forgiving in terms of digital signatures for the consent part of it, which has always been a barrier for some of that. But at this point, they are all on site. That does not necessarily mean that the visit that we are doing is on site with the patients. We do telemed where we may adjust medications. However, we can get digital signature for our consents that way.
Yeah, and ours aren't official CDTMs, but outside of that, I would say we're all on site. We do have the ability to do video visits, but the majority of our patients, they prefer to come in. And so that's something that we're still trying to navigate. We always give the option, but most of our patients prefer to come to the clinic.
Anyone else want to chime in on that question? Okay, yeah, go ahead.
That's okay. I was just going to add, we do a hybrid of telehealth and in person, just like the rest of the group. So our pharmacists could either be on site or off site. It really depends on that particular clinic session. And the second part of the question is whether any patient outreach is done from a central location off-site or remotely. For our postpartum RPM program specifically, we aren't necessarily doing any patient outreach at this time, just because we're starting a new program and slowly building it up. We do have patient outreach as part of our workflow, or proactively identifying referrals, I should say, for the rest of our clinics. And that can occur during a regular administrative day, or doesn't necessarily have to be at a specific location per se.
Okay, great, thank you. And Lisa's last question is, any tips for success with parodic commingled packaging? She's had difficulty onboarding patients with external vendors and often takes several fill cycles before all meds are in the specialized packaging. Patients find it confusing to have to use a combination of vials with box.
Yeah, so I think I can answer this or help answer this. What I try to do, because I know it can be confusing when the patients have both, is try to short fill if there's going to be certain meds that they just had filled and aren't going to be due yet, and that's going to push out that Parata or first med box fill date. I'll try to short fill them in a vial so that way they aren't getting a med box without all of their medications. I typically try not to send them a med box that doesn't have everything in it. So maybe they'll have a 3-week supply of a few meds in a vial until they get to their med box date, and explain to them, 3 weeks from now, you'll have your med box, everything will be lined up. if there is something that they just got a 90-day supply and it's pushing us out to say November, December, then I would reach out to social work and say, hey, is there any chance we can cover this one medication? Just for this reason, everything else is going to line up, and go from that end and see, that's typically how I try to do it, because I don't like them using both either.
Okay, thank you. And the last question is, are the pharmacist telehealth visits covered by most insurances? Probably, I think Hanlon and Amber.
So we currently are not billing for our postpartum RPM program, but we do plan on exploring the billing portion. When discussing with some colleagues here locally who do bill for their RPM program, it is typically covered by Medicare, plus minus Medicaid, which is a large portion of our patient population. And I can't speak to commercial because I know those typically vary by insurance, and can vary significantly. But we do plan on exploring billing for our RPM patients.
This is Sarah, and I just wanted to jump in. So for our service, we are not currently billing. However, that is something we also are pursuing. We are credentialed through the health system, and we are pursuing credentialing through payers as well. So that's sustainability is important.
And then the next question is, does it matter if the telehealth is phone only or video call?
I feel like that's a really long webinar that we could have a whole separate discussion on. There are very specific rules for telehealth billing. I know ACCP and ASHP both have some pretty great resources on that, but each individual payer has some specific things. And then there's also quality metric issues. Majority of the time, if you're billing, it does need to be a they need to see the patient's face in some way, shape, or form. So the video does need to be there. That's my understanding.
Okay, thank you. Last chance to type a question. Okay, I will take an opportunity, maybe just to ask if you'd like to comment about what we really need to do next to help make this more sustainable and to grow it to where it should be with regard to advancing the role of pharmacists because of the great outcomes that we can achieve. And so, maybe it's a little bit of an opportunity to talk about, what we should be doing from an advocacy perspective. If Chuck Schumer were sitting across from you, what would you say to him? Kind of thing. Sarah, I might have to put you on the spot because I know you've done
I know.
work around this.
I would do exactly what I've already done with Chuck, which is write the letter to say, please, Chuck, can you support I can't remember what it's called anymore. The CARES Act, HELP Act, the pharmacist considered as providers at a national level for CMS. And so I think that's advocacy for recognizing pharmacists in terms of their contribution to health equity and patient outcomes is huge. And I think the more we talk about it and the more that we are talking to our representatives and to the people who are in charge of the money is probably the most crucial thing that we need to do on a regular basis.
There you go. Thanks. Appreciate that. Anyone else on the panel want to comment?
I agree with Sarah. I also think that we need to be more forceful about presenting what we do. I think this is a great platform, getting people educated as well, like more pharmacists. So I think this is great that we're starting like with this series and just publishing what we do in this area as well. I think that's all important. But again, yeah, we really definitely need to change some of the laws.
And Gina, I'll just add to yours and say, not just presenting to each other, because I think we all know that we're great. I think we need to be presenting to everyone else. So getting involved in our physician organizations with different areas of specialty, whatever we can do to present to everyone else.
Yeah, I couldn't agree more about that. We're great at talking to each other for sure. Gina, I have one question for you. As a student, that sounds like a really pretty tremendous experience. Like you really involve them in all the pharmacist activities, which is great. What kind of feedback do you get from the students?
So far it's been good. I do think, I will preface, and I always tell people this, we probably opt out to a certain degree because people know what our site's like, and we probably get students that want to come there. You know me a little bit, but I've never been a fan of giving students busy work, so they're going to do what I do, because at the end of the day, like that's what they have to do when they're going to graduate in like 6 or 8 months. But at the site, the students love it. The biggest feedback I've had, and some of you that know me, I was in hospital practice for a long time. Some of the big feedback though I have is just the interactions with the patients, getting to understand who patients are as people and understanding the social backgrounds. In our practice site, it's very important, because if you don't communicate essentially the right way, you just get yes, no answers. I think that's true anywhere, but with the language barriers we have and things. So the students, they love it and they enjoy it, but they have all told us, even the ones, like I said, I know a lot of our students coming through that I'm like, I know that they're ready to come in and get started. They still struggle with that communication aspect, with knowing how to integrate some of the care. And then honestly, just seeing some of the, and you guys all know this as practicing pharmacists, but seeing some of the odd things that patients do, I think as well. And so all of them have told me that they need help learning how to communicate with patients better, keeping those visits on track, learning how to navigate when patients aren't doing things correctly, especially with language and number barriers as well. I think students just forget. We do a lot of diabetes care, and a lot of our patients still have that baseline health literacy assessments. And so just learning to start at the beginning as well, and just saying, hey, you're here for insulin titration, but do you even know what your A1C is? And the numbers of patients that don't know what that is. And then we have to figure out how to provide it in a way that's appropriate and in small numbers, so that they can go home and keep track of things and stuff like that. So it's been a great experience, I think, for all the students we've had so far. But again, a lot of challenges and openness with learning how to navigate the communication issues, and honestly, just like being adaptable and trying different strategies that might or might not work with a patient you have to be creative, but it's been good.
Thanks. So, anyone else on the panel have any comments they'd like to make before we conclude? Looks like we have some wonderful comments in the chat. People are very much enjoyed this presentation today. Okay, so with that, I just want to remind everybody that's on that we, as part of this pharmacoequity programming that J&J is sponsoring, as I mentioned in the beginning, that we also are offering a grant program through the Research and Education Foundation, and that's a separate application process. But please, if you're interested, you can reach out to me. You can reach out to the council office if you want to get more information. And I also believe that the information was sent out via email, and it will go out again. And even if you are not able to participate this time, if the time is too short, we understand that the timing might not be optimal for everyone, but know that the REF is really committed to getting additional funding to support grants around this type of thing. What I've heard today is the next place that pharmacy is going to be. How we're changing the education to really think about what the social aspects are, and that each patient we treat as an individual, and that we do need to think about them that way. And I think pharmacists are so well positioned to do this. It makes me very excited. I wish I was young again and I was a student in Gina's clinic, because that sounds like a lot of fun. So with that, sorry, I really get very excited about this, and must have been that MPH I got. So thank you very much to Drs. Prescott, Amering, Travato, and Lee and Bradley for providing our webinar today.